My name is Neil Moore. I work for Aspire in Peterborough, drug and alcohol treatment service. I've been here for 9 years. I've been in my current role for 5. I've actually got a dual current role. I'm BRIC coordinator. So the BRIC coordinator is the volunteer and peer mentor coordinator, the service user lead. I'm also the engagement team leader, which means that new clients into the service, I try to ensure that they have a seamless process into the service. We shouldn't be surprised that people become dependent on drink and drugs, but they do because generally the drink and drugs are serving a purpose for them, often helping them cope with some kind of trauma. The clients that we see tend to be people who have experienced a great deal of traumas throughout their life, and the drugs and alcohol help them to cope with it. But the simple truth is there are far better ways to cope with trauma than drugs and alcohol. And that's the message that we sell to people all the time. And leading on, obviously I know that the overall remit of this was around, cancer diagnosis. And we've seen that. We've seen a number, I could cite at least half a dozen clients in the last 6 years who have been end stage cancer by the time that they have any kind of diagnosis. And when you speak to them, they say that they didn't present because they put a lot of their symptoms down to their substance use. They're used to feeling pain, but also they didn't present because they didn't think that they would be treated favorably, and their historic presentation at hospital or GP surgeries had tended to be a negative one. My colleague, Neil Thatcher, I work closely with him, and he's based at the hospital in Peterborough. He works as a hospital liaison worker. So he, his job is basically to try to liaise between us, the local community drug service, and the hospital to ensure that patients presenting with drug and alcohol issues, the process is smooth. I had a woman who was in hospital, and normally Neil Thatcher will try to facilitate the process so that they're admitted to hospital. If they're already on OST, which is opiate substitute treatment, which this woman was, he will try to facilitate it so that they get their medication in a timely fashion and that they get the correct dosage so that they're not made to feel ill. Unfortunately, on this occasion, this woman attended, she was admitted. Actually, I think Neil Thatcher was actually off, if I remember correctly, because this woman was admitted early, say on a Monday morning, and she telephoned the service out of hours late on Tuesday evening. So this woman was on opiate substitute treatment and had gone, at least 36 hours from the time of her last dose. She rang, and it just so happened I was on the out of hours service that day, and she told me that she hadn't been prescribed any medication. Now, if Neil Thatcher had been in work that day, he would have seen her and he would have inputted all the information onto our system, and I could have accessed that. But there was no information available because Neil hadn't been in work that day. So I spoke to the ward, and the ward reported that the lady had been prescribed and she'd received her dose earlier that day in the morning. And I was like, oh, okay. Oh, I'm sorry, I'm sorry to mess your time around. So I spoke to the client, the service user again, and she strongly disputed the fact that she'd had any medication. She said that she hadn't been given it. She'd been told it would happen later, but it hadn't. So I rang the ward again and spoke to them. And they were insistent that she'd had her medication. They said that she couldn't be trusted. She was lying, etc., etc. Anyway, eventually it transpired she had not been given any medication. On the ward, they had assumed that she had been given it the night before, but she hadn't. So the next morning she didn't get it. And then on the night, of her second day of stay, they again assumed that she'd been given it before. And it turned out she hadn't been given it. So this was somebody who's on, opiate medication and had been disbelieved basically, and not trusted. And I struggle to think of any other circumstance where a patient would be treated in that way, where they may be on medication, from their GP, etc., and they would be disbelieved when they tell somebody that they haven't actually had their medication. There are what they call at the hospital. I mean, even the term is not, it's a bit of a pejorative term. They call them frequent flyers, and they're clients who are regularly admitted to hospital because of health issues linked to their substance use. So, one of his jobs is to try to limit, how many representations they get of service users. But he does find that, our service users are regularly treated poorly, with lots of stigma, lots of assumptions made about their behavior, and not really, very compassionate. And I'm old enough to remember, in the 90s, I was a drugs worker in London, and I worked for a really, really good local community voluntary sector service, very small, but busy, on the Old Kent Road. But we did lots of joint working with the statutory services. But the statutory services that I saw at that time were very hierarchical. It was power down. It was top down. It was not co-production. It was, we do things to you. The medical model. And I understand we're dealing with opiate substitute treatment. So I recognize that an element of the medical model will always, but I just don't think it works. That, being directive, compelling people to do things. So, I much prefer a different approach, and that is about empowering people and, having that, as you said, not top down, but also not, bottom up. So not, and having that adult to adult relationship with our service users. That's what it's about. It shouldn't be about infantilizing them or making them dependent. And it was, in the early 2000s, really, when the recovery agenda bloomed, on the back of sort of peer-led organizations in America, really, saying, actually, we want more than that. We don't want to be maintained in our dependency or our addiction. What we want is recovery and to live a life without substances. So that's really when that kicked off, and services now, there's a sort of hybrid system whereby those who are viewed as, can get off, i.e. on the non-opiate substances, get off and carry on and live their life in the community, supported by other people in long-term recovery. It happens less with the opiate clients, and that, I think, is because there's this OST, and it acts as a barrier sometimes to people recovering, because they can be maintained in their addiction or maintained in their dependency. So that's not to say that no opiate clients stop using. They do, but I think as healthcare professionals, we need to look at that. Are we sustaining people in their addiction because we can, because there's an easy, substitute medication? Lots of our clients, they're sometimes second and third, even fourth generation drug users. They've never seen anyone who's stopped before. They've never experienced it. They've never been in the company of people who have, are in active recovery. So having people around the service, what we're not asking for is any individual to sit down and say, this is my life, my story. We wouldn't expect that level of disclosure, but just the fact that you can say, he's a peer mentor, he used to use these services, or she's, they used to come here, is really powerful. And it can be really motivating for people when they go, oh, right, they're just like me. They're ordinary. They're like me. They're not, if they've done it, I can do it. And that's the aim that we have. And, it does work. Talking therapies and treating people as human beings and treating them with compassion is the only thing that works. And that's what we need to endeavor to aspire to. Everyone in society. I run the group here for our affected others, and we get so many people coming through that group, people from all realms of society, all social groupings, all ages are impacted by substance use of others. And, you know, I don't think there's a family in the country that hasn't been impacted by that. So it's nonsensical to stigmatize and shame people who have developed problems with drugs and alcohol. The only way to work with them is to show them compassion, show them love and respect, and encourage them to recover. They can absolutely recover, and recover with the strength and support of other people that have already followed that pathway.